Thanks to the guys for 3 great presentations. It's now time for your questions. I guess while we're waiting for the first question, I'll ask one, a practical one. I'm an insurance executive, and I really like what you've said. Sometimes financial incentives are not the right things to do. We need to nudge physicians in a different way. Let's talk about a huge problem that you all alluded to and Kevin talked about most recently, which is remembering to take your medicine. What is the first thing, based on the research you have today, you would tell that insurance company to try, and how would you roll it out?
I would use a program that provides automatic refills for chronic medication for patients who are on lots of medicine. There are financial barriers, that's clear, but removing them and making copayment 0 tends to only improve adherence by about 4 or 5 percentage points. So making it convenient and in essence lowering the hassle costs and remembering when each refill are due and just having those refills arrive automatically would probably be the one thing I'd do if I could only pick one.
I agree. I think that has would have a strong effect. There's other things. A lot of it's an empirical question, and we need to do more research in these particular areas. But I'd say getting patients to pre-commit and reminding them of their commitment might be important.
Yeah, again, Kevin is one of the experts on this. They've done some clinical trials with some really clever behavioral incentives, which has shown some promise. Unfortunately, once you remove the incentives, behavior tends to backslide a bit. I would say also thinking about trying to create good habits, trying to reinforce behavior, taking medication at a particular time in a particular environment and giving some primary reinforcers to that to start to kindle kind of good habits might be another approach.
Bill Marder, Truman Health. I don't know what we get by setting up the straw man of the purely rational idea of economics and contrasting that with behavioral economics. So maybe you can help me if there, and actually there were variations among the 3 papers about how much you did that. A lot of us think about positive transaction cost. Mm-hmm. A lot of us think about time costs as part of making decisions. And all of the things that you're suggesting as part of behavioral economics, I think can be understood as, nice ways to present information, that the nudges are really lowering transaction costs. And I may be missing something there, so my question is, what's missing from the lower transaction costs versus behavioral economics?
If you want to stretch the rational actor model to include all kinds of things in your utility function or make assumptions about information that's conveyed through social interventions, I think you can kind of get to a place where you argue, well, that's kind of rationalizable, but that means you have to add a lot more parameters to your model and a lot more ancillary assumptions. Whereas I think a lot of behavioral research has identified exactly where you should be looking. For instance, I mentioned very briefly the example of the importance of defaults. In economics, you could say, well, there's a transaction cost, right? There's a transaction cost, for instance, to deciding I'm going to opt out versus opt in. But that doesn't really tell the whole story, and it makes it very difficult to account for the fact that you're getting movement and organ donation rates, for instance, from about 15% to about 99%. So I think, in fact, trying to stretch the rational model to accommodate the behavioral principles obscures where some of the best opportunities are. And it obscures the fact, for instance, that the social influences are often much more powerful than the financial incentives. You have to tell some story about how that's just a very important part of one's utility function and so forth. So I happen to disagree.
I think the key is to really think through the implications. So if people were fully rational, we'd really just be focused on the size of the rewards. And if you think about something like mental accounting, yes, you can think about it in a rational framework, but so much of it really relates to thinking about what does this mean in terms of how you would design the programs, and it's probably less critical to think about which model is the best model, as opposed to thinking about if you're going to design this program, let's say you have a certain amount of money, there are lots of ways you can design it, and there's some which would be effective, some which would be ineffective. And so, for example, if I bury your incentive to quit smoking into your paycheck, you can bury a lot of money very quickly and nobody would ever know. So we can try to explain why that doesn't work, but if we then pull that out and I hand you $500 and that works, mental accounting is a nice way to explain that, which is really, I think, a behavioral enhancement to some of the thinking that preceded that. So, I think there's a lot of opportunity to really think about how we design these programs that really goes beyond what's typically happening in the field. One of the big limitations to what's out there is that when you look at insurance benefit design, when you look at what a lot of employers are doing, a lot of this thinking hasn't really taken hold. And I think there's an opportunity there to make much better use of the money that's already being deployed.
So actually, I have a question kind of stimulated by Casey Mulligan's observations. What about markets, you guys? You're talking about, here's what we ought to do. Now, who is this we that have been nominated to be the master puppeteers, either of us as consumers or physicians? And I guess the alternative way of thinking about it, this is at least the way I've been thinking about it, I wonder what you think, is to think of the demand for nudging. If you tell a group of physicians, let's say, we all agree it's desirable to reduce the rate of antibiotic prescribing. Here is a menu of ways to do it. Pay for performance, regulation, social norms that make you feel terrible if you're doing more. Of course, it's always the guys down the hall that are doing it, but make you feel terrible, reframing things, and in a way, let the subjects decide how they would like to be manipulated. For one thing, I guess my question is, does anybody know anything about that? And for another thing, what do you think about it?
You ought to come to our 3 o'clock session. Joel Hayes is going to present on clinician preferences for these interventions that we gave. And I won't give too much away, but their preferences don't correspond with how well the interventions work. So we'll have to look at that. I think, though, to answer your question, Craig had mentioned libertarian paternalism, and I think this idea that there is no non-biased way to present information to people. And so given that, and given that there's a potential for these negative externalities that nobody wants, like antibiotic-resistant infections, we ought to consider alternative ways of framing information.
I agree with that, and I've got a couple of things to add. So, taking off where Jason left off, Thaler and Sunstein in their book Nudge give the example of a buffet. And we know that if you set up a buffet in a particular way, you can end up inadvertently nudging people to consume, for instance, maybe the food that's up front. So, or things that are less within reach. We know people tend to take less in buffets, the way you group things and so forth. You can either set up the buffet in a mindless, arbitrary way, or you can do it in a mindful way. So absolutely, I think that we should be setting up healthcare choice architecture in a mindful way. Secondly, with respect to what is it that the providers want, I think that a lot of people are a little bit uncomfortable with these kinds of behavioral interventions because it comes across to some people as coercive. Now, most of the kinds of interventions we talked about today, as Jason mentioned, if people don't have really are effective if the providers don't have a very strong preference, and those are exactly the people you want to nudge, and the people who have very weak preferences are the ones that you do want to nudge. But that said, there's some recent research, actually. Kevin's, one of his collaborators, George Lowenstein, has a paper on defaults and what happens if you pre-inform people that they're being exposed to defaults. This is in the context of advanced directives. And it turns out, actually, it doesn't neutralize the effect of the default. So it may be possible to be completely transparent and yet still have these kinds of interventions be effective. The last angle that I might take this is a different angle when you talk about what the providers want. I think it's a really kind of suggests some interesting ways in which regulation could work together with behavioral interventions. If you create the demand among hospitals, for instance, if I heard some news item on NPR yesterday, which you guys probably are more familiar with than I am, the details, because I was only half paying attention, but there are going to be some new procedures in which hospitals are going to be evaluated on performance metrics, and those that are in the bottom quarter, I think, are going to have money from Medicare, I think, reimbursements reduced a little bit. Anyway, if you create a sense of urgency over outcome measures, then that may create a demand among hospitals and groups to seek out and consult with behaviorists to come up with better ways of improving their performance on those metrics. So I think that suggests a really interesting angle.
Well, I think another key point in thinking about Mark's question is, you know, if we think about pay for performance or provider payment and how that's likely to evolve, a lot of this relates to what entity is bearing the risk. And the self-nominated group of people who would be charged with trying to figure out how do we most efficiently produce health or short-term returns on health, or whoever's running the ACO. On the patient side, I think similarly, it really relates to, you know, is it the employer, is it the insurer, whoever the entity is that's overseeing this population of people, they're the ones who would have a reason to try to think differently about how are we currently producing health, and is the money we're using, you know, if 97% of it is going to treat disease after it happens, are there things we could do to more efficiently use some of these benefit dollars to have a healthier and more productive workforce, for example?
Well, I'm going to have to call this plenary to a close to allow you to get to your 1:15 sessions, but I hope that all of our speakers will be at dinner tonight, and there should be a lot of time to engage them individually. Let me thank all three of you and all of you for coming.